I reviewed some of the abstracts presented at ASCO looking at treatments in local regional lung cancer, and the 4 abstracts that I reviewed the first one looked at the role of metformin with chemoradiation in patients with locally advanced non-small cell lung cancer, and the study was looking at if there was any benefit in the endpoint of progression-free survival in patients who received chemoradiation as therapy for stage 3 non-small cell lung cancer. This study was an NRG study that started enrollment before we understood the role of maintenance immunotherapy in this patient population, which is now a standard of care. But the study involved enrolling patients to either metformin with chemoradiation and consolidation chemotherapy or no metformin at all. And unfortunately, this was a negative study. Metformin did not improve progression-free survival or overall survival. But what was interesting was how well the patients did in both arms. In this study of non-small cell lung cancer treated with chemoradiation, we saw a 2-year survival rate of about 65%. With chemoradiation, and that's very similar to what we see in patients treated on the Pacific study that introduced the role of maintenance immunotherapy, which is now a standard of care. So I think outcomes for stage 3 non-small cell lung cancer are improving even with using immunotherapy as a maintenance strategy. In looking at surgically resectable lung cancer, I also discussed 2 abstracts investigating the role of neoadjuvant immunotherapy in these patients. The LCMC3 study looked at neoadjuvant atezolizumab, and then the NeoSTAR study looked at neoadjuvant nivolumab or nivo-ipi in patients who had surgically resectable lung cancer. Both of these studies showed that neoadjuvant immunotherapy is very safe to administer and for the most part does not affect morbidity of surgery. There was a decent efficacy seen with neoadjuvant immunotherapy in both studies as measured by major pathologic response rate. In the LCMC study, the MPR rate was about 19%, and in the NeoSTAR study, combination nivo-ipi MPR rate was a little over 30%. And so those are both seem to be effective strategies in patients with surgically resectable lung cancer. These are not quite ready for prime time, and there are ongoing immunotherapy studies in phase 3. Many of them are actually looking at the role of the combination of chemo and immunotherapy, which is now a standard of care in metastatic non-small cell and small cell lung cancer. And then finally, I reviewed one abstract looking at the role of a new drug called lurbinectedin in patients with small cell lung cancer in the second-line setting. This is a drug that inhibits transcription factors and actually did show some efficacy in the second-line setting of small cell lung cancer. What's impressive is that there still was some efficacy even in patients who had platinum refractory small cell lung cancer, which is a very difficult group of patients to treat. We will need to see some phase 3 data of lurbinectedin before this is going to be ready for prime time. It'll also be interesting to see how the combination of chemo and atezolizumab, which is now our new standard first-line regimen in small cell lung cancer, will impact how this drug can be used.